Good morning, Chicago. I'm Dr. Allison Arwady, Commissioner at the Chicago Department of Public Health. Today is Tuesday, January 25th, 2022, and for those who may not be aware, yesterday marked the 2-year anniversary of the first COVID-19 case that was detected here in Illinois. That wasn't a Chicago resident, and it brought me right back to 2 years ago when there was so much we didn't know about this virus. And I just want to note that anniversary and note that I never expected we would still 2 years in be doing this, but we are, and I appreciate you joining. We will be taking your questions directly, as always. You can use the hashtag AskDrArwady on either Facebook or Twitter, or just put your questions into the box below. As always, we've gotten a lot of questions in, and I'm going to answer some of them, actually highlighting some things on the dashboard and on some of the data sources online so that you can go back and take a closer look. So let's start with our data dashboard. CHI.gov/COVID- is how you get there. And the data here continues to look really good. It's amazing to me that, Omicron started here early December, and here we are not even at the end of January, and we've seen this very rapid increase in peak and then this very rapid decrease. So we're currently averaging just under 2,000 cases a day, continuing to drop by about 50% compared to the prior week, and that has been consistent and excellent. Hospitalizations, we're averaging 154 Chicagoans newly being admitted to the hospital with COVID every day. So that's still high, but it is down 28% from last week, and you can see that's looking good too. Deaths still are quite high. We're still seeing a little bit of lagging in terms of death reporting because the medical examiner has had so many to evaluate, but we continue to be in the kind of 19, 20, 24, 25 range. That is too early to be calling a flattening on, but the rest are looking good. We are doing between 9 and 10,000 new vaccinations a day, and we'll talk about that, about 32,000 tests a day. And that has been pretty stable week over week. So remember, we always look at cases and tests together if we're going to be using these. And so a 48% drop in cases compared to a 3% drop in tests tells you that is a real drop in the amount of COVID. It's not just a testing artifact. And then we see that reflected in the positivity rate, 7.9%, down from 14 a week ago. And I am very, very pleased to have that back into single digits and continuing to see this level of progress. There have been a number of questions over the last few days about pediatric cases and how are those reported and what's happening in schools. And I just wanted to remind you that right on the Chicago data dashboard here, if you go to cases, you can take a look at any time period that you want. If you want to take a look and just see what's happening here, for example, since end of November, beginning of January here, you can just slide it in. Let's just do that one. So like November 30 to the present. And this will show you cumulative totals over that time period, 807 deaths over that time period, et cetera, as well as daily averages. But if you go to cumulative totals and then you look by age, you can see here over this time period, this is all pediatric cases that are reported. So since the very end of November there, 38,000 cases in 0 to 17-year-olds, 305 hospitalizations, and 1 death. And then you can look and compare how that looks against different age groups. And then you can do the same thing. This is cases, this is hospitalizations. So again, hospitalizations remain very low in terms of comparing to the other groups in the dark blue here. You can look at deaths, where luckily extremely, extremely rare for younger people, but not zero. So all pediatric cases reported in the city are here. And I just wanted to remind you, you can do the same thing if you want to look by race, ethnicity, or gender. That's where you can explore that. Okay, I also wanted to just highlight a couple of things on the website that we've been getting a lot of questions about. So one has been about treatments. And for example, we had Alejandro Guyana on Facebook asking about treatments. Let's see, we had Well, that's one of them that I'm seeing right now. But we've had a number of them coming in. Lots of questions about what treatments are available, where can I get it? So I wanted to just let you know, right up when you're on the dashboard, right up at the top here, therapeutics represents what's happening in terms of being able to treat COVID. And if you go down here, it will tell you at the very highest level what's available. All of these are available in the city of Chicago. Supply is limited, but it's available, and we've been checking in. And so just to review this high level, because people have been like, what about this one, and what about this one, and what's good? I just wanted to point you here. So there are two major classes that we use to combat the COVID-19 virus, especially in early people who are recently infected, to try to help keep them out of the hospital. There's antivirals that at the most basic level are trying to stop the virus from copying. They don't stop you from getting infected, but they stop it from copying, and then monoclonal antibodies. And so among the antiviral medications, there are three that we use early in infection. So there's Paxlovid, and if you click on it, it'll tell you about it. It's oral, meaning it's one of the pills. It's currently under EUA, emergency use authorization, for the treatment of mild to moderate COVID. This one is 3 pills total, taken twice a day for 5 days. It's good for people 12 and up that weigh at least 88 pounds, who have mild to moderate COVID, but importantly, who are at high risk of developing severe illness. People who are older, have underlying conditions, et cetera. And you can click and read more about that. But importantly, therapy must be started within 5 days of developing COVID-19 symptoms, and sooner is better, because again, this is helping cut the copying. And so it's really important, especially if you have an underlying condition, contact your healthcare provider right away if you test positive. That includes on a home test, and you're at high risk of developing severe illness. And then importantly, you know, as it says here, you cannot just get these medications. You can't go to a pharmacy or infusion center without a prescription. You got to call your doctor, your healthcare provider, because there can be interactions, particularly with Paxlovid, that we got to make sure it's an okay drug for you. Molnupiravir is the other oral antiviral that's under emergency use authorization. That one is 4 tabs twice a day for 5 days. This one is for 18 and older. Similarly, mild to moderate, who are at high risk. And again, you got to start within 5 days. This one can't be used during pregnancy, so there's contraception things related to that. So again, for both of these, you got to see a doctor. They'll look, they'll check to make sure folks aren't pregnant, et cetera. And then finally, there's remdesivir. Remdesivir is actually the first, this is like one of the oldest COVID-specific treatments, was initially approved for treating people with severe COVID in the hospital way back in 2020, and is now recommended by the NIH treatment guidance for that mild to moderate COVID-19, meaning shortly after somebody has been infected on an outpatient basis. That's what's called an off-label indication, which is what we call it when it has had the full approval, which it has. It's not under EUA. It had full approval. The original work was done for that approval for people who were already really sick and in the hospital. But now, after the studies, it is also recommended for use ahead. So this one is for 12 and up, again, who are at high risk of getting illness. This one is an IV infusion, and you take it over 3 days. This one you got to start within 7 days. And it's a little more widely available right now, and so that one we're using. And then finally, monoclonal antibodies. There's been a lot in the news. Monoclonal antibodies, they're proteins, they're made in the lab, that mimic the immune system's ability to fight off pathogens such as viruses. So particularly if people aren't vaccinated and they get COVID, or if they are vaccinated and they get a breakthrough case and they're at serious risk, this in a temporary way kind of increases the antibodies that are available. These also have to be IV or under the skin. There's 3 types that originally had emergency use authorization, but only one, and it's called sotrovimab here, works against Omicron. So they've actually pulled now, this is the only one now that's being given in the US. And this one, also age 12 plus, who are at high risk. This is a one-time IV infusion. You got to give it within 10 days. But all of these, earlier is better. So the bottom line is, feel free to explore on this, but we really want to emphasize that anybody who is being diagnosed with COVID at this point, even if it's on a home test, rapid test, whatever, if you're older, you have an underlying condition, or you're just concerned, reach out to your healthcare provider. They know. We've given the information about, how to connect. We've worked to make sure that that various settings have some of this available. Hospitals have it. Clinics associated with hospitals know how to get it. Federally qualified health centers have it. There are some pharmacies that have some of this available, but you have to be evaluated by a doctor because there can be interactions. Different than a vaccine that can go to anybody. This is only for people who are already infected with COVID, and it's sort of a secondary level of prevention. So I hope that helps on some of these therapeutic questions. And then similarly, I wanted to just dive in a second on some of the wastewater questions. Ivy Vine and others on Facebook wondering a little bit more about what's happening in wastewater. And so I also just wanted to show you kind of where some of that is. So if you're back on our regular dashboard page, remember this is, the stuff down here on the dashboard is what gets updated every single day. And then up here at the top under latest data is where we're putting things that we might only be updating every few days or every week, sort of depending. This is where our breakthrough data is, our variance data, and then here's our wastewater surveillance data. Hospital capacity here actually is updated every day, so it depends a little bit. But this is where things that we're looking at, you can find everything that we're looking at. So let's look at wastewater surveillance. There's a lot of words on here, so I'll let you take a look. But for those of you who haven't been following, wastewater is kind of a fancy name for sewage, and it's water from households and sewers that can contain poop, human fecal waste. And so the idea is you've got people, and if we look at this little graphic here, you have people who either have symptoms or they don't. They can shed virus in their feces, in their poop. Not at a level that it's infecting other people, but at a level that if you do some of that PCR and other testing, you can identify that the virus is there. Those then, you flush the toilet, it goes into the sewage system, and we take samples at the treatment plant. And then we analyze that wastewater for SARS, and then we are able to use this data to inform public health actions. And then we've been doing some more specialized testing, things like genomic sequencing, looking for variants. And so all of this is really new, is the bottom line. And there's more in here about the details, and you can check. But if you look here, like here's what was happening with wastewater data in December. This got published, I think, last month. We're doing this about monthly. It's not ready for full prime time yet. This is really at a point where we're collecting data, working with people around the city and around the state and around the country to have some standardized definitions. But I want to just show you how it's working. So first of all, there are 3 big wastewater treatment plants that cover the Chicago area. That's what they're named. And you can see when we say the blue here is actually the city of Chicago. So this is not just Chicago, but Cook. And at these 3 wastewater treatment plants where we're working with the state and others, we're monitoring that. And you can see very broadly here, as would be expected, this shows the SARS-CoV-2, that's the virus that causes COVID, concentration at the wastewater treatment plants. So 4 different plants, and you can see with the collection that's sort of being taken weekly, you see a rise in how many copies of the gene you're having per liter. And you see it start to rise right around the 14th, 21st, 28th, and there's a lot of variability here, which is why this line is kind of the 2-week average. And then if you look in comparison, what are the cases of COVID-19 in Chicago residents? And you see a very similar pattern here, right? Where like right at about the time it really starts to take off in wastewater, it starts to take off, in cases at the high level. And then in addition, CDPH is doing some more focused wastewater sampling, from 7 different neighborhoods, 1 in each what we call our Healthy Chicago Equity Zones. Remember, these are where all of our community partners are organized around these tables, et cetera. We started, and this is all brand new with new federal funding, and we began directly supporting monitoring of wastewater just in late 2021. And so you see these blue areas here, gives you a sense, these are the catchment zones, meaning as opposed to all of the data that's coming into the wastewater treatment plant for the whole region here, it's just in these smaller areas. You can see there's different sizes. The zones range from 10,000 to more than 215,000 people. Again, as we're learning how to standardize, we wanted to do this in some settings that had pretty different testing numbers, different demographics. Again, as we're setting up this system, we're continuing to learn about how to standardize. So if we just look at that very high level, first of all, this is just showing you on the left some of the raw data, and These are over the same time periods. The left is what we're seeing in wastewater. The red on the right is what we're seeing in cases out of that particular catchment area or neighborhood. And there are the blue shaded here on the left kind of gives you what's called the confidence interval, that it's probably somewhere in this range. And you can see similarly, we see increases that reflect increases at this level, but it's still quite general. And Chatham in particular, which is the really small one, we're using the whole zip code of cases here, and we're not seeing much difference here, even though we're seeing big differences here. So I just wanted to give you a flavor of where this is. We will continue to update it. We are submitting this data into the CDC's National Wastewater Surveillance System, and that is really the work, kind of like variants. It's not just about what are we seeing here, it's about understanding that in the larger state, regional, and national context. And so that is going to be a publicly available dashboard that pulls county level data, and that we will be linking to in a way folks can download and use, because it'll be more standardized and we'll have more understanding. But this is just some of where we are. We're going to keep doing updates. There's lots more details here. There's also some of this specialized testing that we've been doing, places like the jail, places like O'Hare Airport, and we have seen, for example, even the genomic testing. We detected Omicron, right around the time the first detected case of Omicron in Chicago was resident was identified clinically. We did identify it for the first time in the wastewater samples. And so, this is some of what we'll be building and continuing to learn about, because it doesn't matter if people have access to medical care. It doesn't matter if they're getting treatment. It lets us really understand what's happening at the eventually sort of at the city level or even the neighborhood level. And we're really excited about this work. It's new and it's important, and it's the kind of thing that needs to grow, in my opinion, and is growing across the country, just like the variant surveillance. Okay, so that was a lot, but I did want to show you some of that. Let's go ahead. I've got a few more things here just to answer some of your questions. First of all, people are saying, how does that fit into the risk matrix? Here's how it fits into the risk matrix. So in terms of our cases now, we are calling all 4 of these metrics as decreasing. It's very good news. Cases remain at very high while we're over 800 a day, and test positivity has moved from very high to high. Hospital non-ICU capacity has moved from very high to high, and ICU, which actually never got to very high, has moved from high back to substantial. This is what we want to see. We want all of these heading toward lower, and it's really good to be seeing that progress. So yes, those of you who are saying, does that mean that we're seeing progress in the high level things? Yes, we are. And then we also got some interesting questions of people being like, why are you still talking about COVID vaccines? Nobody is still, everybody's gotten a COVID vaccine who's gotten one. Stop talking about it. And I just want to highlight that, actually, there are thousands of people every day in Chicago getting their first COVID vaccine. You can find that data on the website, but I thought I would just highlight, this is just from last week. These are the zip codes in green here that had the biggest percent increase from the previous week for first dose vaccine uptake. This is not boosters. This is people getting their very first dose. And so just last week in these zip codes, this is just the number of people who last week was the week that they decided to go ahead and get a vaccine. So in 60629, for example, we had almost 1,000 people last week get their first COVID vaccine. In 60624 here, we had 232 people, et cetera. And so I know it may feel to you like everybody's made that decision, but they haven't. And we continue to do thousands and thousands and thousands of vaccinations, including multiple thousands of people for the first day. So it's why we want folks talking about it. We got a question in about this, was the CDC guidance changing on kind of what up to date and fully vaccinated, and what is all that meaning? So just wanted to highlight, you've heard me and us using this language, but we are more formally, the CDC is adopting it. Fully vaccinated continues to mean you've received your primary series of the COVID-19 vaccine, meaning you've had 1 dose of J&J or 2 doses of either Pfizer or Moderna. And fully vaccinated, the reason we say fully vaccinated is that is the most important thing in terms of protecting you. When you've had that initial vaccination series, that is what has been required. That's what you need to show currently to get into high-risk settings in Chicago. That's generally what most employers are requiring, et cetera. And it's the most important thing. However, with Omicron, with surges, for people who are higher risk, and really at this point, as you know, we recommend for everybody getting that booster dose when eligible. And so we're using the term up to date to mean that you have received all recommended COVID-19 vaccines, including any booster doses when eligible. So let us know if you have other questions about that. It's just to try to be consistent with how people are talking about this. Up to date means you've had not just your primary series, but you're not due in terms of being due for a booster. So if you just got those thousands of people who just got their first vaccine, they're not due for a booster yet. They are both fully vaccinated and up to date. Whereas somebody who got 2 doses of Moderna a year ago got fully vaccinated, but is not up to date because they are due for a booster and haven't had one. And we are going to be following both of those and using that language. So I also just wanted to highlight that there are many more, there's a lot of testing availability again here in Chicago. And as you know, we've been growing that. Reminder, you can order your free at-home test from the federal government at covidtest.gov. Your healthcare provider has testing available, community health centers, there are pharmacies, and more of that is becoming available, and community-based testing. I just again wanted to highlight that there are 3 sort of expansions that the health department, the Chicago Department of Public Health has funded 2 of these, and the state health department has funded 1 of them, that are the Shield Illinois, some of this saliva testing that people are very interested in. And so I just want you to know these are open to the public, and they have availability. So at the U.S. Courthouse, right downtown, Monday to Friday, 9 to 4, and then supplementing that to have a couple of weekends, the DePaul Loop campus, Tuesday and Thursday, 4 to 7. These are times that this is open to the public and free, and you can come and get the testing. And then Northeastern Illinois, up at 5500 North St. Louis, this is the state-sponsored one, Monday and Wednesday 9 to 12, Tuesday and Thursday 2 to 5. Please do make an appointment. There's a click there. You can also find the link, of course, on chi.gov/COVID-test, but I just wanted to highlight those are new options, and the ones downtown are ones CDPH has invested in to kind of quickly open some where there is capacity to more community members or people who may be working downtown, et cetera. Trusted messengers, of course, remain the key to protect Chicago. And I just wanted to remind you about the free vaccine ambassador course at Malcolm X College. It's at ccc.edu is where you can find the link to actually take the test, and there's information online too. But there are 4 modules here. They're short. They each take maybe half an hour. And the first one is just about COVID and the US healthcare system and explaining information about it. Module 2 is about COVID-19 vaccine questions answered. How does a vaccine work? Basics, explaining it. Module 3 is about having conversations about vaccines. For those of you who, are talking to people, and I hope you are, about your decision to get vaccinated, and how to, some real tried and true ways of how to do that. And then there's a bonus module that we've added recently related to kids and vaccines. So we'll be, sharing out, and we have often. But I just want, those are open to the public. You do get a certificate from City Colleges of Chicago, Malcolm X. You don't have to live in Chicago. There is no cost, and I would love people to take this. It's a nice opportunity to dive in on some of these issues. And I think particularly the Module 3, having conversations about vaccines, gives you some very practical tips. If you folks that you're worried about in your own circles who may not be vaccinated. And we've seen thousands of people do this, but we'd love to see even more do it, and please take a look at that. And chicago.gov/protectchicago is where you can find the link. And then we also, a bunch of questions of why are people still not getting vaccinated? And I know there are people who are feeling frustrated about this. And I want you to know we do collect this data in a whole bunch of ways. So where we look in the last month or so, 12/19 to 1/15, when our team is doing case investigation and contact tracing, calling people who have recently been diagnosed, calling people who are contacts, doing outreach, we of course are asking them if they're vaccinated. If they're not, we first try to sign them up for vaccine. Can we get you an at-home appointment? What is near you, et cetera? Or we figure out how to get a test to them. These are higher risk people and settings. But also, we talk to them about why are they not vaccinated. And the biggest specific reason across all race ethnicity groups still that people give are concerns of safety about the vaccine. They continue to worry that it's not safe, or they have a concern about a side effect not being safe or a long-term thing. And so, we continue to try to emphasize some of that, but you're going to see us doing even more of that in the weeks to come, because right here in Chicago, it's the #1 main reason. You'll see access at this point. Maybe not even 1% of people say it's an access issue. Religious objections are in the kind of 1% to 2% range for most race ethnicities. And the biggest group is actually just refused without wanting to talk about it further. And we have seen that group increase month over month. And this is where I'd love people to sort of do that vaccine ambassador work, because what we're interested in is having a conversation. It's not about convincing somebody, it's about answering their questions and really understanding that. So, and you see in green though, down at the bottom here, there's a good number of people who are like, I'm undecided, I might get vaccinated, or I plan to, I'm now interested, or I'm getting scheduled. And we take care of those when we talk to them. But there are folks doing it. And then our Healthy Chicago equity zones, this is where we are reaching Chicago's trusted messengers. In each of the zones here, remember there's a lead organization. These are the leads, and I want to give a big shout out to Phalanx Family Services, the lead in the far south, Greater Auburn Gresham Development Corporation in the near south, Swedish Covenant Hospital in the north and central region, Northwest Center for Housing, or I think now they're just called Northwest Center in the Northwest, and then Southwest Organizing Project on the Southwest, and then on the West, Rush University Medical Center on behalf of West Side United. And then in turn, each of those leads receives funding from the health department and then also distributes some of that funding to community-based organizations in every community area in each of those regions. And they are together working to set strategies, to decide where vaccination events should go, to do collected outreach, with schools and working on connections to get people signed up for at home. These are really a lot of the folks doing so much of the most critical outreach and so much of the lift in terms of building some of that confidence and working on that issue. So I just want to give a shout out to them. And as a reminder, vaccination at home continues strongly. We've got availability, 312-746-4835. It won't be availability for tomorrow because we're confirming. We always confirm, but looking sort of a couple of weeks out, we are more than happy to get you signed up right now for vaccines. And then our vaccination clinics at the city colleges continue to go really well. Even this last weekend, which was cold and snowy, we had 300 plus people at one of the colleges and 500 plus people at the other. A lot of people getting first dose vaccines, a lot of people getting boosters. So we are sticking at it and making good progress. As always, chi.gov/COVIDVax or 312-746-4835 with any questions. Okay, so let's get into some more of your specific questions. Give me just a second to navigate back over. Okay. Oh, someone's giving a shout out. Ismael Enriquez says, shout out to all contact tracers in the CDPH team. I don't know who that is, but thank you. And any shout out to contact tracers in the CDPH team I always like, because they continue to focus. Okay, we've got a few comments here about the UK. So Miriam Cutler on Facebook says, what needs to happen to unmask our kids? Why can the UK do it, but the US can't? And Liz from Twitter says, I've heard more and more infectious disease experts say masks could be optional in schools no later than February 15. We should be moving to focused protection. And the UK and Denmark are thinking about removing vax passports. When will Chicago allow mask optional in schools or think about getting rid of vax passports? These disproportionately impact children who are at low risk of severe COVID, vaxxed or not, allow choice. Okay, so the number one reason why, I'm sorry to say, we are not fully like the UK there is that the UK is quite a bit more vaccinated. So 91%, where we look at people 12 and up in the UK, have had at least that first vaccination dose. And it's going down from there. But you know, we are not there, and we are especially not there in families in some of our least vaccinated areas. And when we're thinking about schools overall and safety in schools, we have to be in a much better place and ideally much more vaccinated. We get to a point where we're talking about high levels of vaccination. Yeah, and Liz, to your question about will we be making mass optional in public settings? We don't control the schools. That's a state level decision. And the quote vax passports, by which I think you mean the requirement for vaccination to get into high risk settings, both of those are only while we are in this higher risk status, right? I've been saying that all along. That has not changed. When we get back down to that level 2 as defined by the CDC, we get back down to that lower risk, both the vaccination requirement for high-risk settings and the indoor mask requirement for public settings will come off in the city of Chicago. Schools, I'm not going to get into the details of that because we've seen that there are there are more levels there in terms of lots of stakeholders and opinions, and we've got a lot of schools that are really poorly vaccinated, honestly, still in Chicago. But this will continue to be based on data, and as risks come down, I do anticipate both of these things will happen. Okay. Emina Minka Dervovic on Facebook. Can the COVID-19 vaccine, Pfizer or Moderna, affect results for a past infection antibody blood test? Are the antibodies of the two different? Okay, let me just make sure I've got that question. Can the COVID-19 vaccine, Pfizer or Moderna, affect results for the past infection antibody blood test? And are the antibodies of the two different? Okay, good question. Let me sort of, again, take a little step back there because there's a lot in that. First of all, it's not that you get, quote, different antibodies really in a way that you would pick up on a test depending on the type of vaccine, Pfizer or Moderna, but the type of antibodies that are different that you would actually detect on an antibody test, the big differences there are whether they are antibodies that may have come from, quote, natural infection, basically a previous infection that you've recovered from, or antibodies that have come potentially from being vaccinated. And just to kind of give you the super high level on that, there's two big classes that we're interested in. There's one that are called anti-N. Anti means antibody. N means the nucleocapsid. So remember what COVID looks like? You know, where you've seen the electron microscope of this, there's sort of a round ball and spike sticking out. The capsid, the nucleocapsid surrounding the nuclear area here, the nucleocapsid, the part of the virus itself, that is the N antibody. And if you saw the virus itself, like the real virus, you had COVID in the past, we would expect that you would have the N antibody be positive. Okay, does that make sense? Because it's the nucleocapsid, it's the actual virus. Your body saw the actual nucleocapsid of the virus and learned how to make antibodies against it. The other big class of antibodies are called S, anti-S antibodies. S stands for spike. So S, do you have spikes on the real virus? Yes, of course you do. But also, how does the vaccine work? It teaches your body to recognize the spike and make antibodies kind of against the spike. And so if all you've had in the past is a vaccine and not COVID infection, you would be expected in most cases to have a negative nucleocapsid, negative N, but a positive S, because the S is just about the spike. And so the problem is most people don't know this when they just want to go and try to get an antibody test. And the thing that the antibody test is actually authorized for under emergency use authorization, first of all, this is not a test to diagnose COVID. Let's just make sure we know what we're talking about. So this is not the PCR test for am I sick now. This is not the at-home test for am I sick now. This is not a saliva or a mouth or a nose swab. This is a blood test that your doctor takes or your lab takes. And the only thing it is actually like EUA authorized for is to see, did you have COVID infection in the past? Yes, no. That's the only thing it's authorized for. It does not have authorization to tell you anything other officially than yes, no. There are some that report what we call not just qualitative yes, no results, but they'll report quantitative or what we call semi-quantitative, meaning you might get a number, and then you're trying to maybe interpret that number. But anybody who, and everybody's very clear about this, including the manufacturers, there actually is not a standard that has been determined at the individual level that tells you for sure I'm protected. That is especially not true for people who have been vaccinated. Now, why is this? Number one, everybody's immune system responds differently, and level of antibodies is not the only thing to follow. There's B cells, there's T cells. The B cells are giving your humoral response, making the antibodies. The T cells are kind of coming along behind. There's memory B cells. There's lots of different pieces in this. There's no such thing as one test that tells you right now whether or not you are protected. This is different than measles. Measles, you can go to the blood test. I mean, you can go to the doctor and get a blood test. It's called a titer. And they can look and say, you know what? Your vaccine that you had back when you were a kid against measles, it still looks good. It's at a high enough level. I'm not worried about you. You don't need to get a measles booster. They don't do this for everybody, but if you're going to work in the hospital, like I had to get this. And I'll tell you, actually, when I first started working in a hospital setting and I got my measles titer taken, they were like, your measles titer isn't so good, actually. We can tell you had your vaccines, but it's not as high as we'd like it to be. So I got a measles booster, an MMR booster when I was like 20-something. But we do not have that at the individual level for COVID. And so lots of people are like, which antibody test should I take? How do I know if my vaccine is working? How do I know if I had remote? Number one, these antibodies don't last. We're still learning how long they last. We know from SARS and MERS, which were the big two coronavirus outbreaks prior to COVID, many of them lasted, at least at some level, kind of in the 18-month range, maybe, but that's like on average. And they certainly, we know, because we've seen with Omicron and all the rest of this, they don't last in a high protection way for months and months. Are you good for about 3 months after natural infection? Generally, yes, but this last Omicron variant has thrown a little bit of a wrench into that. Is there some level of protection for 6 months? Probably. But is there a level of protection you can get on an antibody test that says, I don't have to worry about this because of prior infection? No. 5 to 10 to 15% of people who clearly had COVID infection, their antibodies don't show up at all. Doesn't mean they're not protected, but the test you'll have a false negative. And then similarly, people have a very mild infection, it might show up, it might not. People who have a more severe infection to have higher. All to just say, there is no recommendation at an individual level to get an antibody test to know whether you are protected. I have never had an antibody test. I am fully vaccinated and boosted. And I trust that that is the most important thing to protect myself. I have not had COVID yet, a little bit to my surprise, given that the whole world has had COVID, but I haven't, despite a lot of testing. And I'm careful, and my vaccine and my booster continue to protect me. But if I were to take one of these tests, first of all, I would want to know for sure what kind of antibody this test is. Is it N or is it S? As somebody who has not had COVID, I would expect my N to be negative, and I would expect my S, my spike, would probably be positive. All that tells me is I probably didn't have COVID, and I probably did have a vaccine. It does not say you are protected, even if numbers are coming back. I can't know that, and we can't use that at an individual level. We use it it's really important at the population level. These serologic tests, what % of the population are we seeing numbers, and that's how we kind of like the wastewater. We're still sort of learning a little bit about what is normal, how do these different numbers respond to protection. That work is happening. Will we have a titer eventually? I sure hope so. Do we have a titer for influenza? No, we don't. It all depends on the virus, the way it behaves, the variants, the levels. So you can get an antibody test, but please don't think the antibody test is going to answer the question of whether you are fully protected now. Especially for people who are severely immunocompromised, their doctors will use this sort of in a more specialized way to say, you're really not getting any response, let's try this, let's try this. But you should be doing any antibody testing. The point is, with a doctor or a healthcare professional who knows how to read these N's and S's, and you should not be thinking, okay, I'm good, or oh no, I'm not good. Somebody wrote in and said, I've had 6 different versions of the vaccine and I still don't have antibodies. What I would say to you is if you've had 6 different versions of the vaccine and you still don't have antibodies, it's possible the antibody test you're using is looking for N and not S. I don't know, because I don't know the details. It's also possible that you have an immune thing you don't know about and you should talk to your doctor. The most likely thing is you're just not producing a positive on that test, but you're protected because of the B and the T, et cetera. So talk to your doctor about it, but don't use an antibody test. Oh, and the other thing is if you've just gotten COVID, those don't show up for like at least a few weeks. Like, don't even try to do an antibody test for 1 to 3 weeks. And they're just telling you about the past. They're not telling you about now. So long answer to your question, but I hope, we just have gotten a lot about this and I think it's worth chiming it in there. Okay. Jason Guthers from Twitter. Why hasn't Chai Public Health created a pandemic control initiative similar to San Francisco or New York that can provide space or food or money to allow people who test positive for COVID to properly quarantine rather than risk returning to work prematurely? Oh my goodness, we have. We absolutely have, and we still have it. Like, we have the ability, and even during this Omicron surge, we expanded the ability that if there are people who are unable to do this, including if they're homeless, including like you name it, we have the ability to both do what we call shielding housing, where we have people who, for example, may not have a place to be, can't quarantine, et cetera, who don't have COVID, like, there's a hotel that is still going that we are sponsoring, et cetera, for some of that. And then for people who are sick, like really being able to isolate them. And we have an entire COVID resource hub. That's the other thing. So absolutely, when our case investigators and contact tracers are calling, they're not just asking people, do you have your vaccine, like that data I showed you? They're not just working to make sure people have testing and vaccine. They're actually connecting people to resources. So we absolutely make sure people have food. We absolutely make sure if they're needing help with, work notes, et cetera, that we're doing that. And our COVID Community Response Corps does that. So please rest assured that is absolutely something that we do and continue to do. Okay, Grant Christopher Maquette from Facebook says, when will an updated vaccine be made to combat more recent variants? And Justin from Facebook says, will a new vaccine be rolled out soon? So on these questions, so Grant, there is work happening around a quote unquote updated vaccine. But what that may mean, I think, is a little bit dependent on what happens over these next few months. Because the good news, the excellent news, is that the current vaccines that we have do a beautiful job. As you know, I've showed you over and over again. They not only help protect people against infection, right here in Chicago, just during Omicron, people who are unvaccinated, twice as likely to get infected as people who are vaccinated. So although the risk is certainly higher with this variant of being infected than it has been, being vaccinated is still the #1 thing in terms of helping to protect yourself. But also, more importantly, they've been critical at protecting people against severe illness. 5 times as likely to get hospitalized, die, et cetera, et cetera. And so there is work happening, but frankly, I thought, my expectation, I'm going to be honest with you, my expectation was that we were maybe going to see a new formulation of the vaccine made for this variant, but then when the data came out, it actually was not needed because the protection was very good, and it's more important to sort of get those boosters in quickly and build that protection back up. And that was studied, not just here, but in South Africa, the UK, et cetera. So will we be at a point where this, you've heard me talk about this becomes more like the flu, where there may be an annual booster, if you will, or an annual COVID shot, just like there's an annual flu shot? Might those be combined? It might be. I don't know for sure. But the research is going on that, but I am not expecting a, quote, updated or vaccine, and Justin, to your point, a new vaccine to be rolled out soon. I do not expect that. There's a couple of vaccines that were in early trials, Novavax, et cetera. I don't think those are going to be soon. I think we'll see more options for kids probably. Certainly we're watching for the 0 to 5-year-olds, but I don't anticipate anytime very soon a new vaccine or another recommendation for another booster or a change in vaccine or any other change. Lizbeth Tavermina from Facebook, please, what are the prerequisites for taking the vaccine ambassador course? Great question. There are none. You just need an email address. And so if you go again to chicago.gov/protectchicago, the link to the course is there. Or if you want to go there directly, it's at pages.ccc.edu/apply/mxvaccine. But go to chicago.gov/protectchicago. It is meant for everybody. And it's free, and we want everybody to take it. So love that question. And if you do take it, give us feedback. Do you have suggestions? We added that child module based on some feedback. Okay. Let's take just quickly here. Faded from Twitter, Faded spelled with a PH, says, number one, if there was a measles outbreak at a school, would you recommend closing it, or would you tell parents to grin and bear it? Number two, if the answer is the former, close schools, then why is Chi Public Schools open during a peak COVID wave with the most transmissible variant to date? Okay, this is a good question. Number one, if there were a measles outbreak at a school, would you recommend closing it, or would you tell parents to grin and bear it? Because measles vaccination is a required vaccination to go to school, let me explain to you that we don't see measles outbreaks at schools. However, where do we see measles outbreaks? I worked myself on a measles outbreak in Cook County a few years ago, published on it and everything, where there was somebody who was exposed to someone who had not been vaccinated as a child, et cetera, et cetera, et cetera. I'm not going to get into details, but that person came into a daycare setting. When do we start to vaccinate for measles? The first dose generally is given at the age of 1. The second dose is generally given at the age of 4 before school starts. That has to do with the timing of how the immune system is developing, et cetera. But you can't generally vaccinate kids who are younger. Occasionally we'll do it if they're traveling to a country that's high risk for measles. And in this daycare, you know what happened? Virtually every child under 1 got the measles, all but like one of them. So did children over 1 get the measles? No. Did adults get the measles? No. Do kids in schools, in Chi, et cetera, get the measles? They don't, because vaccination rates are really high. Where we have ever seen measles outbreaks is only in settings where, for whatever reason, you get a pocket of people, the one here was age, they're too young, that are not vaccinated, and it's very infectious. So the difference here, a measles outbreak in school, every time there's a measles case in Chicago, I want you to understand this, my team is super on this, because it's very infectious, much more infectious than even Omicron is. We are completely on that, and we look really fast to say, who was in contact with this person? Was anybody not vaccinated? Or is there anybody who's pregnant, because you got to do some extra stuff there, or under 1? Those are people you can give them. It's sort of like the same thing as the IV. There's a secondary thing you can do to help try to keep them from getting the measles. But do we look carefully to make sure we don't see the spread of measles? Yeah, but where they're vaccinated, we just don't see it. So I appreciate the question, because I think it highlights there are a lot of differences between measles and Omicron. Number one, measles used to be a leading cause of severe illness, leading cause of deafness in kids in the US, big deal, encephalitis, brain, it really affected little kids. We worried a lot about severe outcomes there. COVID, thankfully, as you know, less likely to lead to those severe outcomes at starters. Number two, schools are not major sources of spread. We've continued to absolutely see it's really what's happening in the community that drives that spread. And then finally, that where we're, quote, closing, we're only doing that, there are a lot of negative implications for closing a school. And if you were to have a measles situation, let's as a thought experiment, there's a school where everybody's very much against vaccine and they've all gotten together and been unvaccinated. Yeah, one measles case, virtually everybody unvaccinated is going to get the measles. So would the people who got the measles need to go? Would the people who were unvaccinated need to go? Yes. And actually, I don't know if you know this, but people who sign, if people get a medical exemption that their child, for example, can't be vaccinated against the measles, there's a whole process for that. They actually sign something saying if there's a measles case in the school, my kid will stay home, because the risk is just too high. And so the comparison to Omicron here is, yeah, we're having to quarantine, we're having to isolate. I don't love doing that, but do I need to do that at the school level? No, because we're not seeing, even where kids come in with COVID, we rarely see that spread in the school setting because of the mitigation measures. And there's a widely available free vaccine that is very effective, especially against protecting against severe outcomes. Okay, and Tony D on Twitter, how come the vax requirements discriminate against people who have had COVID in the past, have natural immunity, and are not supposed to get a vaccination for some time after infection? There's no caveat to go to rules for people to go to restaurants, et cetera. Okay, 2 things on that. You do not have to wait to get a vaccine after infection. Let me say that again. You do not have to wait to get a vaccine after infection. That's true for a first dose, a second dose, or a booster. If you get infected with COVID, please wait those 10 days where you may be infectious, right? The 5 days at a minimum you need to quarantine. If you're feeling better, the mask, et cetera, wait those 10 days. Day 11, go ahead and get your vaccine. So first of all, you can get it. Number 2, some of the reason I was talking about these antibody tests, et cetera, is there is no existing test that tells me whether somebody is protected, right? If we had a measles titer, if there were an antibody test that at an individual level, I could say, oh, you know what? This person's antibody levels are high enough that I can trust that they are protected. We don't have it. And we know these antibody levels fall over time. And so in terms of really thinking about this at the system level, the best protection out there, remember, is people who have had both the combination of having COVID and been vaccinated. That time and time again has been shown to be the best level of protection. The next level of protection is people who've been vaccinated but haven't had COVID, like me. The next level of protection is people who have had COVID, natural infection, but not been vaccinated. But especially with Omicron, we saw a lot of those people get sick again, get hospitalized, even die. It's just not protective in a long-term way, and it's been shown to be even less protective with Omicron. And then finally, how are you going to keep track of this? So this vaccine requirement is not in place forever. It is in place because in high-risk settings, we can't run the risk of highest risk. It's just like the measles people. People who aren't vaccinated against measles, they got to stay home from school if there's a measles outbreak. This is like, that would be a high risk setting for them to be in. People who are unvaccinated, they can't be, in any setting where there's a higher risk for spread that we can do something about. And adults have had plenty of opportunity, kids have had plenty of opportunity to get a vaccine. So for these optional settings, like you can still get restaurant food to take away, you just can't sit down and take out your mask. I know that it is hard to not be able to go to a bar, but we know those are settings where we've seen COVID spread, including of Omicron. I know that people want to be able to go to some of the sporting events and the theater events. Right now, if you're serving food or drink, you got to take a mask off and you're not vaccinated, there's just too much risk at a population level that you could get seriously ill and end up in the hospital. And that is part of the job of staying open. I'm extremely proud as a city. We have not had to shut anything down. We have not had to put any capacity restrictions in place. We have not had to close indoor dining. We have not had to do any of these things going all the way back to last April, when we finally fully reopened. Why were we able to do that? Because most people got vaccinated, frankly, and have continued to do so. And we've used more of the vaccination and testing to help keep some of those larger settings safe, and I like that. But in this surge right now, vaccine was the most important thing and is the most important thing in terms of keeping people from getting seriously ill and protecting the hospitals, and I want us to stay open. So it's not in place forever, but it is in place now. And am I discriminating, quote unquote, a little bit against people who have made the choice to not get vaccinated? Yeah, probably I am. But am I doing that in a way that keeps them from things that are essential, like school, like grocery stores, like the ability to do things that are part of the essential things of life? No. But are there some optional things that are known to be higher risk, like bars, indoor dining, and large indoor gatherings where masks are being taken off? When the risk is high, that is a decision that we've made, and that is a decision to keep these places open and operating, because I don't want to shut them down, and I know you don't either. The people who don't like this don't want everything shut down, and that's a balancing act, always. But I hope you don't think about it as discriminating. I hope you think about it, and we are seeing, we don't just ask people why aren't they vaccinated. We've been polling people who are getting their first doses of vaccine every day at our clinics, and just in the last few weeks, we've heard, a lot of people are saying, especially young people, 18 to 29, 30 to 39, a lot of people are saying, I don't think I'm really at risk, but I want to be able to go to the bar. I want to be able to go to the X game. I want to be able to do that. And if that is what is motivating people at this point, that wouldn't be my reason for doing this, but if that's their reason, I'm all about it. And I want to thank people who have stepped up and made that decision. And it is your choice not to get vaccinated, to be very clear about that. But that choice does have consequences for other people. And it is my job to think about how we protect the things that we love as a city, and keep the risk in them as low as it can be. And all of the restaurants have not had the ability to put in all the ventilation stuff and everything that the schools have had. And so it's philosophical, but that's some of the answer. And then just as a super last question, Deanna on Facebook, I tested positive January 10th and I'm fully vaccinated. When can I get my booster? Right now, assuming you tested positive January 10th, it's been more than 10 days, and that is a breakthrough case. I've been recommending to everybody get your booster, so you can go ahead and get it. Schedule it. Chai.gov/COVIDVax, or your pharmacy or your doctor, lots of availability. So great questions. And Nikel Peterson on Facebook he's got a long question here, or she's got a long question, I don't know which, asking about, the employer wants to know, do you need to test somebody coming back to work? You do not need to test. There is not a requirement for a negative test to return to work after COVID infection, because PCR tests in particular can stay positive for weeks and weeks and weeks. So they need to complete their isolation period. They should not be returning, of course, if they are still symptomatic, and there's some details about that. Fever needs to be gone, et cetera. But in terms of the return after COVID infection, there is not a need for testing there. There are employment settings that are requiring, if there still are people who are unvaccinated, to be doing some ongoing screening testing, and we can get more into that if people have questions. But in terms of protection after or testing after return, especially if you're doing regular testing, PCR tests can be positive for some time, and so antigen tests are probably going to be preferable in that setting. Okay. We are at noon, so I am going to sign off. We actually do have a press conference at 1 o'clock today. CPS is going to be there with us, just doing some higher level COVID updates. And then on Thursday, we're actually planning a lightning round where we're going to compile a lot of the frequently asked questions, and I'm going to do my very best to answer them very briefly, which those of you who follow me know is not my strong suit. But we're going to hit on some of the things that we're just hearing a lot and try to get through a very, very lot of questions. So if there are kind of quick things that you're still worrying about, send them in. It won't be a day, probably. I mean, there may be something we decide to go into more in depth, but we're going to try to kind of get through a lot of things quickly, just for awareness. So that'll be something different. And send some questions in, and we will see you on Thursday at 11, normal time, for the next Facebook Live. And we will see you this afternoon, if you're interested, for the press conference at 1 p.m., continuing to share the good news of being past the peak, but still not at a point where, we're breathing that easy yet, and that especially goes for our healthcare colleagues who continue to be very stretched. Thanks. See you soon. Bye-bye.